50 minutes, we'll focus on airway clearance in the management of airways in the neonatal population. Let's take a look at some of the learning objectives. I'm going to explain some of the indications for airway clearance and techniques in neonates, describe the types of airway clearance techniques, illustrate the equipment used with these techniques, review the hazards and how to address them, evaluate the response to therapy. So if you want to, clear the secretions, how do you know? Some of the major things that you would, the clinical findings you would examine in order to say, is this effective? Examine artificial airways in neonates, the actual airways themselves, and furnish you guys with additional resources for those that are so motivated and want to learn more about these topics. So some of the traditional airway clearance techniques, so postural drainage is something that we've mentioned in our other lectures that related to neonates and young pediatric patients. Percussion, and they can be coupled, so you can couple percussion with postural drainage. You have vibration of the chest wall, which can be done manually, but much more commonly today is done through a vest or other adjunctive device. We'll focus a little bit on suctioning as well, and using appropriate suction pressures and size suction catheters and things along those lines. We'll talk a little bit about mechanical insufflation and exsufflation, so also known as a coughlator or inexsufflator. And we'll look at some adjunctive medications as well, different substances that can be used to thin secretions and help open up the airways to facilitate the process of secretion clearance. So you have, I certainly believe in, starting with the basics. Let's not overcomplicate things. So for individuals that have a sufficient cough effort, so, basically, coughing, deep breathing and coughing, forced expiratory technique, that can even be like a huffing cough, okay? For patients that are in pain or neuromuscular patients, that they have found that if we can teach these patients that a huffing cough, not just one blast, but multiple huffing coughs, all right, can be effective also. You can combine both, deep breathing and coughing and that huffing, forced expiratory technique. Positive expiratory pressure, so PEP therapy, there's a variety of PEP therapy that's out there. The cough assist, autogenic drainage, and then combining some of these can be, result in some great benefits as well. Selecting the patient, so what kinds of things you actually do to say who's suitable. We adopted, so the hospital that I'm affiliated with currently, hospital system, adopted the Epic electronic health record system about 3 years ago. And I only bring that up. This isn't a sales pitch for Epic. There's certain things I love about it. There's certain things that I'm a little bit less of a fan about, but overall, I'm a huge fan of Epic or Epic-like electronic health records, because there's a function called the summary. And it has so much information in such a consolidated manner. So the reason why I bring it up is it can be very helpful for, that page, if you will, the patient summary. It has chest x-rays on it, so you guys can look at chest x-rays. It has lab values, so you can see if the white blood cell count is going up, and then you can combine, they're looking at other lab values as well, but you can combine that with going to looking at, just other findings, sputum cultures and sensitivities, going to the notes and seeing, what the nurse and the respiratory therapist has been suctioning, if they've been suctioning the patient, what they've been suctioning out, et cetera, et cetera. So it's such a rich source of information and pretty efficient way of actually harvesting that information as well. And when I say kind of at a glance way of doing it. So in the veil through which we can look at that is looking at, most places are using electronic health records. If you're not, it's fine. But most places are, and if you're not, the idea is still the same, is looking at chest x-rays, talking when you give a report or you're taking a report, describing the features of the secretions, the amount, the color, the thickness, the smell, et cetera, et cetera. So looking at, some of the conditions, that you'd be looking at. So once you look at the clinical findings, really looking at, well, what kinds of conditions would result in excessive secretion? So, particularly in this patient population, bronchiolitis being one of them, acute lobar atelectasis. So really, it's not so much the atelectasis causing it, it's being the result, for instance, of excessive, mucus plugging, and that the airways that are distal will collapse. Cystic fibrosis, again, this is not a lecture on cystic fibrosis. Autosomal recessive disorder. Again, if mom and dad both need to be carriers, if they're both carriers, then, there's a 25% chance that the kid will not be a carrier. There's 25% chance that they'll have rather 25% chance they will not be a carrier, not have the disease. 50% chance they'll be a carrier, and 25% chance they're going to actually have the disease itself. Sorry for that long-winded explanation, but that's the definition of a autosomal recessive disorder. Neuromuscular disease or injury. So the injury part could be, a C 3, 4, 5 fracture, or it could be something like muscular dystrophy, which isn't really neuromuscular; it's a muscular disorder, or any one of the, the abundance of spinal muscular atrophy, or the other neuromuscular diseases that can absolutely cause not just excessive secretions, less that, but more the inability to clear them. Lung abscess, as you can imagine, that, a pus-filled, pocket in the lung could be very problematic. Asthma as well. So asthma, the secretions tend to be mucoid. So they're not necessarily purulent. Purulent would be, secretions that are associated with an infection. In asthma, they tend to be, not quite clear, but whitish. They have a lot of viscosity, they have a lot of surface tension and whatever. They can be numerous, but it's really more the result of a inflammatory cascade rather than an infectious one. And then really looking at some sample x-rays of, neonates that potentially, again, not just, we wouldn't do this just alone, but potentially, maybe candidates, particularly the x-ray that's, the one that's labeled A and the one that's labeled D. In both cases, that left lung is in very, very bad shape. In D, the right lung looks reasonably okay. In A, not so much, but there's certainly the right lung looks better than the left. So, you wouldn't just say based on an X-ray that the patient actually needs, airway clearance techniques, but other findings, would contribute to that as well. Contraindications, so frank hemoptysis. We're not just talking about a little, the young pediatric patient coughed in there, a little bit of blood. We're really talking about frank hemoptysis where, they're really coughing up a lot of blood. Empyema, really when thinking about whether you're using, PEP therapy or manual CPT, you could really, rupture an empyema, and then you got, now you have a more widespread pulmonary infection. Foreign body aspiration, untreated pneumo, unstable hemodynamic or overall clinical status as well. CF and bronchiectasis. So really, the patients, the length that you're actually doing this, you're not going in and just clapping on the patient's back for 5 minutes. That really doesn't do much good for anybody, whether you have CF or not. So you're looking at, a good 15 to 20 minutes. Again, it may be done in sets. But for CF and bronchiectasis, you'd be on the longer end of the scale, 30 to 45 minutes. And, for any of you who've done CPT manually or using a percussor or something along those lines, is sometimes you go in those rooms, you get a workout. Even if, again, you're using an adjunctive device, really needed more than 4 hours, we're really talking about, every 4 hours. So it's, Q1 CPTs, they would need their own respiratory therapist or nurse. But it's just, you might see something every 4 to 6 hours, something along those lines. And then the patient should be evaluated every 48 hours and modified as appropriate. So again, just my reference point, we have what's called an assess and treat protocol, where we're doing pretty much, if not more frequently, the assess and treat protocol requires us to go back every other day, at least every 48 hours, and reassessing the patient for, do they need more? do they still need the same, do they need less in terms of airway clearance technique? And it also applies to bronchodilator therapy. So we have categories, but in this, the focus of this is airway clearance. So, the standard of care would be at least every other day. Therapy modification. So if you have medical or surgical procedures, so you're not going to do CPT over, a surgical incision. Implanted devices, something that you need to be mindful as well. It's not common to have implanted devices in these particular, these young patients, but it's something that you certainly, if they have a graft or something along those lines, or they had, recently they, implanted, their baby was born without, a clavicle or something along those lines, and there's consideration for implanting it, something along those lines. Brittle bones. Again, whether it's result of, malnutrition or some other abnormality, but you'd want to actually, modify it as well. And you think about it, babies by their very definition, they're actually not brittle, but they're small. So their bones are pretty pliable, but they're small. So you just would need to be mindful of the amount of pressure that you're applying if you're doing something like CPT. And you just doing it very differently than what you would for an older pediatric or adult patient. So Trendelenburg, today we're not really doing Trendelenburg and CF patients, particularly the real young ones, because of the risk for hemorrhage or aspiration. But you also have again, reflux issues, intracranial trauma. You really be careful in that category as well. Increased intracranial pressure in a patient who maybe has hydrocephalus, something along those lines. Abdominal distension. And really the thing we're thinking about abdominal distension is, well, is it distended, and is the patient more apt to vomit? And then they vomit, they're in a Trendelenburg position, they're more apt to then aspirate. Cardiopulmonary failure, it's just the Trendelenburg position is not conducive to oxygenation and ventilation. These are some of the positions that you can actually that are actually used, and again, it's just you think if understanding the anatomy goes a long way, and understanding if you're looking at the X-ray and depending upon where the consolidation of pneumonia exists, you want to put that side up, and if you're combining it with chest physical therapy, applying the chest physical therapy to that particular portion. The preceding slide was postural drainage. You can obviously, combine postural drainage and percussion, but you have this, this young child here who's, being percussed, and it's being again combined with some elements of postural drainage. Chest wall vibration, again, commonly used with cystic fibrosis patients. It's not common for patients that don't have CF, young patients, to develop bronchiectasis, but it happens. It does happen. Patients that are born with the alpha trypsin, the alpha-1 antitrypsin deficiency, and it's they can develop emphysema at a young age, and they've repeated infections, and they can develop bronchiectasis, but it's not real common. So most commonly, the vest would be used for patients that have cystic fibrosis. Cough assist, the inexsufflator, coughlator, whatever. So the version that's shown here is really can be used manually or automatically. There's a if you will, an iteration that preceded this, where the original inexsufflator looked like a 2-gallon paint can with a kind of a semicircular metal tube on the top. We've thankfully gravitated a long ways since there, but I could tell you that facilities invented by Emerson in the late 50s, early 60s, it went through a period of time where it was being pretty widely used, and then it wasn't being used much at all, and now the coughlator has seen somewhat of a resurgence. And a lot of places that weren't using it 10 or 15 years ago are starting to. Another category, I mentioned CF patients, but another category of patients that can really benefit both from the vest and from coughation are your neuromuscular patients. So that's those patients are fairly commonly will receive a coagulation therapy as part of the regimen. So the cough assist, one of my colleagues, he's done a lot of research where it comes to cough assist, and these are what the guidelines. The Respironics now produces them, Philips Respironics actually. So they have some basic guidelines that are out there. So 1 second inspiration, 2 to 3 second exhalation or expiration for 1 to 2, 1 to 3 IE ratio. Inspiratory pressure max of 20 to 25 centimeters. Expiratory pressure max of 20 to 35. Again, a few of my colleagues have said, if you use less than 20, you're wasting your time. 25 may not be enough on the inspiratory side of the equation, even though the manufacturer says that's the recommended. So I'm not personally recommending it, but I'm saying that there have been higher inspiratory pressures that have been used, not limitlessly higher, but 35, something along those lines, with little to no adverse effects. And then you think about sets, so 5 to 10 cycles over 5 to 10 minutes. And you're probably combining this with other things as well, perhaps things like CPT. So the whole regimen may be a 20-minute regimen, again, for a non-CF patient. Monitor of contraindications and, of course, adverse events. All right, now let's look at suctioning. So we'll go a little bit more old school. I still teach respiratory students, so I don't mean to condescend, but these questions still come up on the credentialing exam. So, and it's good. I don't typically work in a neonatal environment, so it's good to review this sort of stuff as well. But for neonates, the vacuum pressure would be less than 80. They say, typically you need about 50 to 60 to actually get the secretions out. So that's where that guideline comes from. But certainly for neonates, keeping it less than 80, for children, keeping it less than 100. And then if you recall, for adults, you can go to 100 to 120. So it is a little bit variable. And the main reason for that is just, minimizing the chances. There's less volume that's in the lung, so you're actually sucking less of the breath out of the patient. And you're also applying less, the tissue is more sensitive, and you're applying less, if you will, pressure to that, negative pressure to that tissue, less likelihood of causing tissue damage. Appropriate length and size of the catheter. So, it shouldn't exceed, half the interior diameter of the artificial airway. And then a little bit more guidance for neonates, 5 to 8 French. For pediatrics, depending upon the size of the pediatric patient, up to 12 French. Installation of saline or other medication is a bit controversial for a lot of reasons, particularly if they have an artificial airway. You could be washing the biofilm down into the lungs. So that biofilm is the film that, the mucus film that builds up on the inside of the artificial airway. And it is not necessarily, the microbes that build up are not necessarily the same ones that are in the lungs. Nasal tracheal suctioning, and another way of actually, you can go through an artificial airway, or you can go through the nose, if you will. Bulb suction for your neonates are commonly used. Closed suction, tracheal suction systems for patients that have artificial airways, tracheostomies, or ET tubes. Suction catheter sizes. So giving you a little bit of guidance where you're talking about the actual, correlating it to the size of the artificial airway, and giving, some guidance along those lines. So you can see, just a couple of examples, for a number 4 ET tube, the suction catheter size would be, 8, going up to 5.5. You can go up to 10. To instill, saline or not. I mentioned the controversy. A slide here talks a little bit about it. So saline installation prior to suctioning remains controversial. The catheter insertion alone may dislodge thousands of bacterial particles into the lung. A flush of saline increases this and potentially distributes it, basically spreads it around. When necessary, low sodium solution may preserve the antimicrobial component of the airway mucus. You remember, you got the sol and the gel level layer. So the mucus is there for a reason. So it's it's our friend and it's our enemy. If it's excessive and it consolidates an airway, it blocks an airway, results in plugging, it's a problem, but it's also protective. It helps remove debris, and also provides, it's kind of bacteriostatic, where it's an environment where bacteria does not like to grow in general. What can happen is, if you're using normal saline, it can disrupt that, because you're removing the mucus, but it can disrupt it. And therefore a recommendation may be to use actually, half normal saline, half strength, if you will, normal saline. It has less of a tendency to, if you will, dilute the antimicrobial properties of the mucosa. And then some other agents that you'll see. So on the bottom here, I'm doing this in reverse here. Hypertonic saline. So 7% would be really often reserved for CF patients. 3%. The good news is, again, bad news is it can contribute to or dilute the bacteriostatic properties of mucus. That's on the negative side. On the good side, it will actually cause fluid to be drawn out of the mucosa into the mucus and will help thin it out. It's also very inexpensive versus Dornase alpha. So Pulmozyme is expensive. If you think back when you learned about the anatomy and physiology of mucus, yuck, right? So you have your disulfide bonds. So it looks a little like a centipede. So a molecule of mucus looks like kind of a centipede. It has a backbone that's actually a protein backbone. And I will tell you, Pulmozyme works on the protein spine, literally, the backbone. Whereas a mucimist works on, if you will, the centipede legs, where the disulfide bonds exist. And again, mucimist used to also be very cheap. It was so cheap that a lot of pharmaceutical companies ceased making it. And then it became hard to get and got more expensive. It's not as expensive as Pulmozyme. Cost matters. We have a clinical a pharmacist who rounds with us, and we discuss these at bedside when we do interprofessional rounds. And the option of using any one of these, we typically don't use. Pulmozyme is pretty much reserved for CF patients and patients that have other diseases where oddball diseases where the secretion, nothing else works. Quite frankly, it's expensive. Mucimist, fairly commonly used, but the studies basically say, acetylcysteine / mucimist, hypertonic are relatively equivalent in efficacy. Complications of airway clearance. So hypoxemia is probably one of the most common. It's transient. So you have to apply, particularly if you're coupling it with like a head down position, a Trendelenburg position, or you're coupling it with, some other, the patient's in an oddball position where they can't breathe as well. So transient hypoxemia is treated by delivering oxygen. Airway obstruction, respiratory arrest. So, the good news is they're getting the secretions out. The bad news is they're in the process of getting them out. They may dislodge a mucus plug that lodges elsewhere and causes an airway obstruction. In the little patients, it can be really problematic because, if enough of their airway gets obstructed, it can result in respiratory arrest, and it could result in cardiorespiratory arrest. And the problem there is our real young patients don't have any reserve. So they will become compromised much faster than our older pediatric and adult patients. Intracranial complications, just again, fragility of the vessels in their brains, big issue. Rib fractures and bruising. That's really for the young patients, but perhaps ones that are malnourished and do have brittle bones, but also ones that the pediatric patients that have CF and we're doing repeated CPT to. It may be bruising less than fractures, but they can get very, very sore from the repeated chest physical therapy. Airway trauma, just from the actual suctioning, and infection is a risk of virtually everything that we do. Evaluation: did the therapy work? The amount of secretions, expectorated, if they're expectorated, or the amount of secretions that are actually suctioned out. So hydration status. The reason I put that here is, hydration status is something that if the patient is dehydrated, the secretions will become thicker with all else constant, okay? However, if they're adequately hydrated, hydrating them more is not going to thin the secretions out more. It's just avoiding a, if you will, a dehydration state is really, really critical. So if there's secretions are thick, you need to then go back and say, is the patient adequately hydrated? That's why it's in this evaluation here. And if their I's and O's, if they've been putting out much more fluid than they've been getting in, and their secretions are thick, it may just be that they need better hydration. Changes in sputum production, the color more or less, it could be in the right direction. It could be that they don't need CPT anymore because they have many fewer secretions, their x-rays looking better, their oxygenation is better, etc. And then breast sounds, vital signs, chest x-rays, we're typically not just, doing serial blood gases for the sake of doing serial blood gases, but if they're being done, they may be reflected in terms of improvement as well. Lung mechanics, mainly in terms of the compliance and the resistance. Documentation of therapy, the technique used, these are things that, you would document, whether it's a manual or electronic health record, what technique or techniques were used, how long they were done, what physiologic locations or lobes that were treated, position of the patient, suctioning, etc., amount and quality of sputum. And then what I didn't put here, but it's really critical, it's, how well they tolerated it. Really, really crucial. So now we're going to just, flip to the related topic in this presentation of airway management. So let's take a look in this patient population. So, some of the need for intubation in our younger patients, they overlap with, with our older patients as well, or adult patients. So indications: lack of pulmonary function, deficits in oxygenation, ventilation, a PaCO2 greater than 50 to 60, PaO2 of less than 60. Sometimes you'll tolerate even 55. The saying is 55 keeps them alive, but things that that you would look for. And then, in some of the actual equipment, the actual ET tube itself, that the age-specific ET tube, the age-specific laryngoscope and blades, laryngeal mask airway as an alternative, suction equipment, oxygenation equipment. We can adequately bag valve mask the patient and bag them up and to prepare them for the actual the fact that we're going to be suctioning them and really suctioning the breath out of them for a period of time. And then there's a lot on this slide, but that's the bad news. The good news is that there's a lot on this slide. So you can really gives you kind of an idea of, what you'd actually do in terms of the size of the airway. Notice kind of, you just go kind of in the middle bottom of this slide, where you look at about 5-6 years old, and you're seeing now where you actually have, ranging from, a 4.5 cuffed, uncuffed. So you get an idea at about what threshold that where there's an option for cuffed and uncuffed, okay? And it's in that 2 to 6 year old range, and then your tubes that are in that 4 to 5 range, and then pretty much when you get north of 5.5, they're all cuffed. So no surprise there. You get and again, there could be a 12-year-old who's failure to thrive, and so they could have the body habitus of a 2-year-old. That's not what we're talking about. We're talking about a typical 2, 6, 10, 12-year-old or adolescent, and it gives you some idea on securing the tube. Now, securing the tube, this is basically would be a starting point. Obviously, your patients moving as we move towards the right portion of this slide. Just to give you guidance, you're going to get the team is going to get a chest X-ray, and you're going to evaluate the depth of the tube, and we'll have to reposition it. If patient's tall or short, or just they may be neither. They may be an average height, but that their airway, the if you will, the distance between their lip and their carina is maybe long. It's just them type of deal. And then all the way over on the right-hand side is giving you some additional guidance on the size suction catheter that you could use as well with that. So a lot of information on the slide. It's kind of one of those ones that, you just slip in your hip pocket if you found yourself working in the, particularly in the pediatric, if you're covering good spectrum of pediatric patients as ages as well here. And then showing you kind of, one of the neo bars, or one of the pieces of equipment that's used to secure the ET tube. There's a lot of different securing devices that are out there. The big issue is that you want to, babies have very sensitive skin. So it's the positioning of the ET tube. Okay, so that you really want to move periodically so you don't get skin breakdown there, but also where it's actually secured to the baby's cheeks. You're really going to inspect that periodically to make sure that the baby's not getting breakdown there as well. For extubation, so, and again, very short list here, but looking at some of the considerations for extubation. Our default is in all of our units, again, of various ages. So our NICU or our PICU and our adult ICUs is patients should be, weaning unless they prove otherwise. And again, for your neonatal patient, it may be that their oxygen index, their P to F ratio is just crappy. Their X-ray is crappy. So, okay, then that's documented that patient is not weaned because, they're still on, high PEEP, they're on an oscillator, or they're potential candidate for ECMO, whatever the case may be. But that's, at some point, the patient is either going to get worse or they're going to get better. And they get worse, they may die. And I don't say that insensitively, but thankfully, a lot of these patients will eventually, the sickest ones will eventually get better because we have a lot of tools in our tool chest. And, we're going over some of them in this lecture and other related lectures. Condition has improved or been reversed. Patients hemodynamically stable. They're starting to breathe spontaneously, so we can transition them from the ventilator to, let's say, bubble CPAP or a high flow nasal cannula. The patient is able to protect their airway. It's really critical. They may have great values, they may, but it may be a simple issue with they're at very high risk for aspiration. You see that with some of your neuromuscular patients as well. Tracheostomy, so looking at the indications, so airway obstruction, airway protection. So the patient may have been intubated, they have a neuromuscular disorder, they're not a candidate for extubation anytime soon, and trach may be the best way to go. So airway obstruction, airway protection, long-term ventilation, again, for some of your neuromuscular patients, pulmonary hygiene. So basically able to better, some of the patients will actually wean better because think about it, the length of an ET tube is as long as it is. An average tracheostomy tube is about a third the length of an ET tube. And the whole issue of the additional resistance that's imposed on the patient by an artificial airway is a function of the internal diameter or circumference, or the internal opening and the length. A little more on tracheostomy. So the different tubes, by the way, there are many different types of tubes. I was with the respiratory students earlier today, and we were discussing more than a handful. But the point I was making is when we're talking about fenestrated tubes, which I'm not going to take a deep dive into now. And we were talking about, but I basically said to them, there's a lot of different types that are out there. So just to focus on a few of them, the high volume, low pressure is really kind of the standard of care today. High volume, low pressure. So the chances of that, when in this case, the trach is cuffed, because it can be uncuffed, not to facilitate mechanical ventilation, but to facilitate airway patency. But when it's actually cuffed, it's the default is it's air filled, it's high volume, it's low pressure, and that so it's low pressure. The pressure it exerts on the trachea is minimal, so that therefore the chance of developing tracheomalacia, tracheal stenosis is reduced. Foam cuffs can be used as well, and again, if you recall, foam cuffs, you're actually the reason why they have a, if you will, a pilot balloon setup is not so much you're basically taking the air out of the cuff. Okay, you're using that to take it out, not adding anything, because its relaxed state of a foam cuff is, if you will, inflated or expanded, if you will. And again, just for the newbies, that we get odd trachs here and about. And sometimes you just have to really look very carefully and, and indeed look up the manufacturer specifications, et cetera. TTS, tight to shaft. So in the bottom right of this slide, it almost looks like a cuffless trach. It's actually not. You can see that because it does have a pilot balloon, but it's a silicone cuff. It adheres very tightly to the shaft and can be used for a lot of purposes, but it's actually used mainly for adult pediatric or neonatal patients that, if you will, have a small stoma. There's stoma issues because they tend to be much easier to insert and to maintain. Some of the complications, that exist. So, again, looking at, preventing, so good training for caregivers, so preventing the complications, the infection, the mucus plugging, etc. And again, looking at, plugging of the tube. So, the cure for that, there are trach tubes out there that don't have an intercannula. They're just a single cannula. Okay. Which makes me really twitchy, because if there is a, if the patient's high pressure, okay, they're on a ventilator, they have a trach, they're high pressure, and you've eliminated all the obvious stuff, and it's not a pneumothorax, but you try to advance a suction catheter and it's unable to advance, you could always take out the intercannula and replace it. Okay. Hence the importance of having an extra, at least one intercannula at the bedside. So that's, again, complications, the plugging of the tube, some of the things that you'd actually do. Accidental dislodgement, so accidental, the patient is decannulated. Let's say that they were moved and the vent circuit stayed, and or they were, they were fidgeting with it, or they became, very stimulated or startled, and they pulled on the tube and actually decannulated themselves. Other complications, bleeding, stomal and superstructural granulation tissue. So sometimes the actual stoma needs to be what's called revised, where that scar tissue and granulation tissue needs to be removed, either with a scalpel, other surgical device, or sometimes it's actually cauterized. They actually do it with a electrical cauter. Suprasternal tracheal malacia. So, really that what I was alluding to before, where the trach itself becomes softened over a period of time because the cuff has been, if you will, impeding both arterial venous flow as well as lymphatic flow. Speech delay and delay in phonation. So one of the things that can help with that in your younger patients is using a passé mur valve, and different types of swallowing complications can exist as well. Decannulation. So now we're talking about intentional decannulation. So you think about some of the indications for extubation. Well, these are somewhat similar. The original condition's been resolved or improved. Natural airway is adequate. The patient can protect their airway. The procedures, generally speaking, it's downsizing and cap the tube. So immediately remove the tube. It's done in different lectures. We talk about the pluses and minuses of different techniques, but immediately removing the tube without downsizing it may not be the best way to go. Also, you remove the tube, you potentially lost your airway if the patient needs to be, if they go into respiratory compromise, soon thereafter. Downsizing and capping the tube is often the way it's done. Extubate after single stage laryngeal tracheal reconstruction. So really, just basically, either the sink or swim or the gradual is really what we're looking at here. Some take-home points. Airway clearance techniques can be beneficial to neonates, pediatric patients, and obviously adults. Adults are not the focus of today's lecture, but certainly can be helpful. There are many techniques which can be applied. So you have this arsenal, and the good news is that the techniques that can be applied can be combined with one another. So things like postural drainage, CPT, can be applied with mucus thinning medications such as hypertonic saline, things along those lines. However, keep in mind that if your drug of choice for mucus thinning is mucimist or acetylcysteine, you really should also recommend that a beta adrenergic bronchodilator be combined with that. That substance can be a bit caustic and can cause a bronchoconstriction. Selecting the best technique should be tailored to the patient and their condition. So really often it's techniques, it's not a technique, but it really needs to be looked at the pluses and the minuses, like we do with our own personal lives, as well as in treating our patients, or patients that have all different diseases of all different ages. You look at what are your choices, what are the pluses and minuses, and what's the best way to go? What does the evidence, what do the guidelines and evidence actually say? Most airway clearance techniques have hazards, like most of the things that we do have hazards, which can be, addressed by the skilled clinician or the skilled team. Careful assessment is the foundation for evaluating the need for the therapy as well as its effectiveness. So just like, evaluating, and again, it bears mentioning again, and that is that, having protocols to assess patients' needs for bronchodilators, for airway clearance, for non-invasive therapies, for oxygen titration. The entire ensemble is really, really critical. That way you're eliminating or minimizing unnecessary therapy, so that the time that's spent is, if you will, higher dividend or higher value activities. And lastly, artificial airways should be suitable for the patient, properly maintained, and removed as soon as practical and safe. Some references here. Again, I went back to Walsh's, but he's also, so I've listed one of Brian Walsh's textbooks, but I also, he also does a lot of the original research. And again, one of them I listed here is a really, really good piece. 2011, it's a little bit dated, but it's an outstanding piece, and really talks about pediatric airway maintenance and clearance in the acute care setting, how to stay out of trouble. Excellent piece. And then you have, your textbooks that are out there, as well as your sources, if you will, your databases, PubMed, Medline, AARC. If there's any nurses in the audience, the AARC is the American Association for Respiratory Care. And they have clinical practice guidelines, and those clinical practice guidelines are based on a lot of the original research that's in sources such as PubMed and Medline.